Hello, welcome to Remaking Medicine with me, Emily Peters. We are here twice a month to talk about progress and innovation and creativity and big problems in healthcare and how we continue to joyfully find our way forward into making a better American healthcare system for us all. I'm very excited to be joined this week with Danielle Carter, who is a longtime friend and client of ours at Uncommon Bold and a really interesting expert on what's happening out in the local level in healthcare. So Dani, please go ahead and introduce yourself and we'll get just ready to dive in.
Yeah, thanks, Emily. Thanks for having me. Really excited to be here. So I'm Danielle Carter, as Emily mentioned. I'm the CEO of Intrepid Ascent. My background is in public health. I've kind of sat at the intersection of healthcare and social services for my entire career in different ways. I started in global public health, working in Africa for a couple of years, and then transitioned to working stateside in community-based public health initiatives for a number of years before transitioning to working within healthcare in particular and focusing on addressing social determinants of health and health-related social needs, really kind of driving that intersection of healthcare and social services. I've been with Intrepid for 7 years now and was privileged to step in as the CEO last January. So it's been a little bit over a year that I've been the CEO of the company. Intrepid is a consulting firm. We're focused on the intersection of healthcare and social services. We really focus on transforming communities by connecting partners. And we do that with two fundamental beliefs. One is that technology is a catalyst for transformation. Tech is here, it's here to stay. It's a driver in our healthcare system. But tech in and of itself isn't going to do anything. People really are the people are really those catalysts to change. And without engaging people in that design and that implementation, you won't actually achieve transformation. So really excited to be here, talk about our lessons learned, my lessons learned of working locally and really engaging communities.
Really, really excited. I think, so much of our conversation in healthcare, if we talk about healthcare progress and reform, is always very much at that national level, right? Talking about what could come out of HHS, and then occasionally at the state level. But why do you think regions are really such an important place, and like thinking down kind of into the individual counties or the individual cities even, or zip codes? Tell us about why regional is like your favorite.
I think regional and regions is really important because it's where we live and it's what defines what's around us.
Mm-hmm.
If you think about designing a program or implementing a program that's just top down from a national perspective or a state perspective, you lose the nuance of what's really going to engage the people on the ground, both the providers. So you're not going to have the trust. You're not going to have the buy-in. You're not going to be able to design a system that's actually going to be supportive of individuals that are delivering that, but then also for the clients or the patients that are being served. You need to better understand what would be culturally appropriate for those individuals. Where's their local grocery store? Are they in a food desert? Do they have access to transportation or housing? What are those common areas that individuals are, if they're unhoused, are staying at, so you can go and meet them where they're at to help support them in different ways? So without engaging kind of that local community, that local voice in that design, you're going to design something that actually doesn't hit the mark and it doesn't have the outcomes that you're looking for. My personal belief is that it needs to be a little bit of a both and. You need to have some sort of national standards. You need to have, some sort of infrastructure that local communities can be looking to, but that should be the floor, not the ceiling. And the innovation is really where that local aspect comes in, where you can start to really think about how do you design from these national standards to something that's actually going to impact the people that I'm serving in this individualized community.
Who do you think are the most powerful potential agents in that setting? We have like the local hospital or the local public health department or the sometimes local health plan, right? Yeah. Like who do you often see, or is it always different in different regions? So like who's really the most powerful?
I think that my answer is kind of unfortunate in that it really varies, right? And that's the whole point of this, is that like you can't design something that's a one size fits all. It really has to be different. I think in a lot of communities, the county is looked to, like the county government is looked to as an entity that can really bring together stakeholders. But in other communities, the county isn't really where people look to and have that trust. I think regardless, federally qualified health centers and community-based organizations are key people or key organizations that need to be engaged in the design and very much engaged in the implementation of whatever that program or whatever that healthcare delivery is.
Then when I think of like an FQHC, that's an organization, at least stereotypically, that is overwhelmed, under-resourced. Do they have time to participate in these kinds of things? Like, how do you make sure that they, in the like million flu shots that they have to give today, can they go and like participate in, sending back feedback to the national level or to the state level, or like how should they get involved?
It's a really good question. I think this is the rub, right? I mean, we've been supporting in California these collaboratives across the state, in particular in 2 regions, is the work that Intrepid has been doing, where we're bringing together local providers to support implementation of a statewide program. It's a really meaningful space, but this question of how do we actually engage in this when we have a to-do list that's 100 pages long, both for FQs, but then also for community-based organizations, often under-resourced. There are more clients they need to serve than they have capacity to serve. I think that the answer is twofold. So I think you need to really make sure that you're clear on the value proposition of why, right? Like what's going to change for people to be a part of this. But then I also think you need to pay them. And that's something that's often lacking, right? Like there isn't often payment for provider organizations to participate in the design or implementation in different areas. It often, the models are that comes in the back end when you are implementing systems. You're able to bill, Medi-Cal in California, for instance, for some of the programs that are coming down the pike. But I would offer, you have to have the right use case, business case, value proposition. But you also, it would be good to compensate for time as well. So it can be a priority and that those individuals can focus some of their energy on really trying to solution.
Yeah, I mean, that's such a simple idea that I have very rarely seen put into action. I mean, we've organized a lot of really great conversations with patients and physicians, and the idea of paying people to participate in that does not often come through. We have a great comment from our friend Andrew in the comments here, just saying, healthcare is delivered in a community. People get care where they live, not in a national dashboard. And he has some really great examples of like, sure, the Mayo Clinic maybe draws people in, but most people aren't living in Rochester. Right. And so do you think there's a national kind of stereotype of like, well, the people out in the community maybe just like don't know what's best for them, right? And we should be helping guide them, right, from our like perch on high.
I mean, I think across healthcare, right? Like it's so top down often. And I think that there is really the sense that patients don't know what's right for them, like as individuals, and that communities just don't understand, right? They're advocating for something that isn't feasible or isn't best practice, instead of actually kind of co-designing with people to understand the why behind it. I definitely think that is a part of the general culture of healthcare in general. I know that's been a big topic of conversation in some of the recent movements over the last couple of years to bring more community-based organizations into healthcare delivery, is the colonization of community-based organizations that it's going to make in that culture. In part because I think there still is the feeling or the sentiment that healthcare knows best. And then that fundamentally changes, the delivery of care that these long-standing organizations have been providing for these communities. So 100% think that is kind of long-standing culture that we still see. I do think it's starting to shift slowly. I definitely think that, there's more and more effort to hear people with lived experience and to engage people with lived experience in healthcare. I know right now, for instance, there's a lot of movement related to community health workers, which is a little bit different than what you're asking, but
Mm-hmm.
I think there really is this understanding that the more there's more and more an understanding that the more you engage people who actually know what it's like to be in the shoes of an individual or know those local programs, the more you're going to see those shifts in health outcomes. So hope is not lost. I think movement in the right direction, but the
Yeah.
long-standing kind of cultural narrative there within healthcare, I think, stands.
This is a debate I have in my own heart all the time too. And I've seen the CEO Scan Health Plan, which has a very interesting history of starting as a patient-driven organization itself. But, we had like a statewide program of, hey, if somebody's in the emergency room and you're discharging them, they need to have appropriate clothing. So they need to have like a winter coat if you're discharging from the hospital. And it's one of those ideas that that makes a lot of sense, right? You want to be sending somebody out to have hopefully not just immediately come back into the emergency room. But then also, okay, now we have like a McKesson coat supply chain that's running through with the billable systems and the padding that goes on that. And it just, yeah, where is the limit of what could be included in healthcare or not, I think is a really big question. Do you feel that tension too of trying to bring in things like housing and food? In some ways it makes a ton of sense. And in some ways it's oh gosh, this could really backfire on us.
Definitely. And I think that, that's where you start to think about partnerships and what does it mean for a healthcare provider to provide that versus a partner with an organization that's been providing that type of service for years. And so, the individual still gets everything that they need, but it doesn't have to all flow through the healthcare provider. But that is the tension, right? Of as healthcare continues to move upstream, it expands the scope and it expands, both what healthcare organizations need on hand in order to be delivering for their patients in real time. But also, the scope of knowledge that providers are going to need in order to address these different needs. So there definitely is a balance that's needed there. But I think that that's where partnerships come in. And that's where you try to create that ecosystem where everyone doesn't have to be everything to everyone, but you can collectively be something that's actually going to move, health outcomes forward and be better for the individual.
So tell me about the work that you're doing largely in California and New York. Give me some examples of things that are happening at that local regional level that might be surprising to people who are focused more on the national often.
Yeah, I can share a couple of things. So we're doing a lot of work with Medicaid transformation in California and also in New York with the different programs that California and New York have. In California, I think we are supporting a lot of organizations with ECM, enhanced care management, and community supports implementation. Some of the things that we're seeing is really kind of bubbling up to the top of best practices and kind of program design. One is really kind of capacitizing community-based organizations to do the work they've always been doing, but doing it at scale now. I think one of the debates in California that's been coming up quite a bit is who should be providing services and who should be providing some of these more health-related social need services, going back to the conversation we were just having. So really supporting organizations and thinking through, is it right for them as an organization to provide these services, and what does this program delivery look like? We're doing that both at the organizational level as well as at the community level, where we're engaging stakeholders to have conversations around what does a local implementation look like for us. And the work that we're doing right now at the community level is in Contra Costa County and in San Diego County as a CPI, or collaborative planning and implementation collaborative facilitator. And some of the stuff that we're doing, it really varies depending on what the local needs of that community are. So for instance, in San Diego, there's really robust data exchange infrastructure. So we're thinking about how do we utilize that infrastructure to support overall holistic delivery of services across community-based organizations and healthcare providers and others who are kind of adjacent to that service delivery. Whereas in Contra Costa, that's not as, the infrastructure isn't there, and a lot of the healthcare providers, at least, are all on one EHR. So it's not needed in the exact same way. And so the focus there has been more on service delivery and best practices related to bringing together perinatal providers, for instance. So it really depends on the local needs. In New York, I think we are supporting kind of holistic thinking around what service delivery looks like in a hub model, which is very different from the model that California employed. I have personal opinions on which one I think is better. But some of the things that we've been able to do there and kind of relates to this conversation is really support local advocacy. So an example of like, why does health matter at the local level is that in New York State, some of the reimbursement for utilities was based off of gas. And it was that we were working on, working in most of the utilities was oil. So the rates reimbursed or fully reimbursed for what the cost was. So really supporting that local advocacy to change the rates and be able to expand reimbursement to meet the community where they're needed. So those are some examples of some of the work that we're doing right now. Happy to share a little bit more.
What are some other, I think we've covered a couple of these already, but like the real pros and cons of that kind of like regional level approach. You know, I think one of the things, especially at the national level, that has been probably one of the biggest challenges in our healthcare system is wanting to have like tight control, tight, you know, visibility into every single thing that's happening. And the idea that that visibility would help us to combat fraud or to, you know, improve outcomes. I think we have done kind of neither of those as a result of those two controls. But yeah, tell me, like, is there, you know, opportunities and also like real risks at the county level? You know, sometimes thinking of it as like a chaotic good kind of level, right?
Sure. I mean, I'll start more with the risk because I think we've talked a lot about the pros and I can come back to that. But I think that the risk when you're implementing at the county level is that you're duplicating efforts, you're wasting resources. There's a lot of people doing the same thing, learning the same lessons at the same time. Whereas if you're scaling and standardizing more in a top-down approach, you don't always have the same amount of wasted resources. I would say this is where like that chaotic good, I actually think is necessary from the start, but then you should be towards standardization. And I think we're seeing this in California, right? The way California has implemented a lot of the Medicaid transformation initiatives has been quite chaotic in a lot of ways. Managed care plans, they have different requirements for provider organizations. It looks different everywhere. Even the CPI collaboratives that, you know, I mentioned earlier that we're supporting, the work is different in each of the regions across the state. And all of the facilitators have been doing similar things. And, you know, now we're at the point where we're learning in California, now it's time to standardize. Now we have the best practices that we can really stand on and say, this is what really works here. So the chaos a lot of times is necessary in the beginning to really figure out what are those kind of nuggets of gold that you want to move forward. And then you can look to standardize after that. Yeah, I definitely understand the, you know, inclination to have visibility into everything and make sure that everything is done exactly the same way all of the time. My counter to that would be make sure that you have, you know, that you have systems to measure. I think that that's been a miss in a lot of these initiatives. But systems to measure so you can actually see progress towards outcomes and then allow for some of that innovation that's on the ground.
Yeah. I mean, I think one project, and we won't name names, but like just you cannot anticipate anything that you might encounter out there on the ground. I mean, we worked together briefly with a health plan and we went out to interview some of their community partners. And I expected very cynically I was going to go out there and I was going to hear, oh, they're terrible. we can never get in touch with anybody. They never support us. I mean, just the kinds of like typical stories you would imagine. And when we actually went out and talked to some of those community partners, they were like, oh, they're so amazing. They help us all the time. We found this like one person in this organization who is connecting us. And you just never know what you might actually find. It's so important to go and question those assumptions, right? And then, you know, sometimes I think that's the local level, sort of a point towards the local level as well, is like, in that example, it was really just a couple people inside of a massive health insurance company who had decided to like make it work, right? And had like decided to create their own program that like was delivering on what they needed. And, you know, are we creating space in our healthcare innovation to let people make it work, right? To like let people find their way to success? I don't think we build that in often. It's just sort of like, here's the instructions. And sometimes the only reason that you might want to really become an expert at that set of instructions is to try to game the system, not necessarily to like try to do what's right.
And I think, you know, my reflection on that project and working with you is exactly what you offered, that like, that's actually, that highlights the benefit of local healthcare, right? Like you had an individual who not only took the onus on themselves to go and have those phone calls, but to be where other people were. Like they were out in the community, they were creating those relationships, they were building the trust, which I think is one of the pros for local kind of design of healthcare, is you have that trust and you have that buy-in. I think, you know, comparing and contrasting the work across the nation, one of the things that I've found is California, the way that at least the Medicaid transformation work in California worked is the state had requirements, managed care plans were the ones that implemented it, and then contracted out with different provider organizations to do the actual service delivery. Whereas in New York, it was different, where they contracted with hubs. And I think that one of the fundamental differences there was that the trust was already built among most of the hubs. I think it depends on where you're at in New York. But some of the partners that we've worked with, for instance, they have long-standing relationships there where that trust is built, where the buy-in is already there. And so providers, as they're thinking about what does this look like for me and for my patients, they know that they have somebody in their corner that they can trust. So from jump, they're already, you know, on board and thinking about what that looks like. So I think that, you know, having in the environment today where there is different types of top-down design, for instance, creating that space as you're offering for those relationships to be built, or a program where you're putting organizations who already have those relationships at the center, I think is really important when it comes to, you know, the ultimate impact of the program.
I love that. Tell me about how technology fits in on all of this. And are we at some kind of tipping point potentially, or is this just, you know, the continued very slow evolution of our systems?
It's a good question. So tech, I mean, my personal belief is tech is at the core of what's going to transform healthcare. But it has to be used, as I said in the beginning. I think technology is being used differently depending on where you are. So California looks very different than New York. Again, comparing those two, those are areas that we do quite a bit of work in. But technology is a necessary backbone in order to make these local relationships actually work. You're going to need to have, you know, the FQHC be able to coordinate and communicate with the organizations that is providing services for individuals who are unhoused, who is going to need to be able to understand if somebody goes into the emergency room. And technology like is the core to make those pipes work. There's a lot of movement right now in tech. I think that there's a lot of opportunity. We're seeing, for instance, across the nation, closed loop referral platforms are really front and center, especially when you think about Medicaid work of helping to support organizations refer electronically. So it's not as much of a fax or a pick up the phone call. And then you can see, you know, the outcome of that. I think that the adoption of those platforms and the use still needs work. We still need to, again, get local and support communities in a way that's side by side, really supporting what those local use cases are for that. I think in terms of, is this kind of an inflection point where we're going to really see continued technology? I think so. I mean, CMS and the feds are really positioning to put technology front and center, and interoperability in particular. Some of their new requirements coming down the pike related to the way managed care plans are exchanging data really is kind of forcing the hand of technology adoption and implementation. So I think that that is going to be a necessary stick, so to speak, of driving forward. I think that the thing that's hard is that the investment still isn't there, especially on the ground. The local investment of what is needed in order to actually build infrastructure that supports communities is, there's still a need to continue to fund those efforts. Hopefully there will be some of that coming down the pike with some of the newer initiatives that are coming, but definitely a gap right now.
I worked on interoperability for a long time, and for a long time it felt like we were building freeways but no cars, right? Just like big giant freeways everywhere, big expensive, like mandatory connect your town to this freeway or else kind of like sometimes attitude. And I feel very like weirdly optimistic, I think, especially around AI right now, of like, oh, suddenly there's a lot of cars. And I could imagine a way like in 2024, equipping a care coordinator with a huge amount of access to interoperability data in an HIE would have pretty limited value, right? Like, yeah, you could get an ADT, which is, the hospital notification, which has always been one of the more like robust use cases, I think, in the HIE world. But, could you go in and dig and get like really good information on like where somebody had been or like what prescriptions they were on and things like that? Not really, right? And I'm very curious in this moment of, now in 2026, could a care coordinator use an AI tool and like have a conversation with it about that client and actually get like really good and important information now, in a way that like was not possible before? And I think it will remain to be seen, can we make that kind of like giant leap in like a secure and viable way? But I'm sure there are care coordinators out there already who have like duct taped together a couple like tools and are just making it work, right?
I'm sure it's happening. And I know that a lot of platforms are building AI into their suite of services. Some are standalone that sit on top of EHRs that can do exactly what you're saying, of pull together relevant information to create a care plan for an individual that's tailored to what the care coordinator's needs are. I think that time will tell what adoption looks like. And then I think that there's still need for additional governance and ensuring kind of safety of that data. In different ways. But I think, some of the announcements that have come out recently about some of the larger, ChatGPT, for instance, and what they're doing with individual health records shows that at least, with individuals, people are already using AI to give themselves information about their own data. So, I think that the trajectory is going to be using more and more of that. And we're seeing that movement in the system. Time will tell what the adoption looks like.
Potentially a lot of opportunity there. We'll see. We'll see if we could get it right. I mean, I think one of the things that back to your initial point, is like not having the actual end users involved in these conversations, right? And so what do the care coordinators and the community health workers and the nurses and the social workers want from these technology tools? It feels to me like there's this huge portal that's opened up of a chance to not make the same mistakes that we made with meaningful use, right? Maybe a long time ago, of just being like, this is the program, it's great, let's see what happens. And maybe now it could be a little bit more like, what would you guys actually want? Like suddenly we have all these freeways. What does it look like to build your own cars or scooters or trains, right, on top of that freeway?
For sure. And I think transition to FHIR, for instance, and some of the newer data standards that allows for more of that interoperability will help us move in that direction. So I definitely think, the path is there. We are walking down the path. There, as you're saying, are more
Yeah.
cars that are on the freeway now. I think it's figuring out what the right cars are, and then, the quality of the roads to continue on with that. And make sure that, the data that's in there is the right data to be able to tell the story.
I'm going to pull up a comment from Jean Ross, who we just love. She's amazing. And she said, healthcare has a national problem solved locally is one of her big talking points. And to change healthcare, you have to start with yourself, your family, and your community. How are some ways that you maybe think about that just yourself as a parent, as a patient yourself? I know for myself, I love being a Kaiser member because I feel like I live in like this utopian future that it's not perfect. It's still healthcare. It's still, rough around the edges, but I just don't have to deal with a lot of the problems that people have to when they're on different systems. How else do you think, just like as an individual, we should be getting involved?
Yeah, I think it starts with, personal advocacy for yourself and your family, right? I think one of the things that I've shared about, on LinkedIn and otherwise, but my mom is on Medicaid. She's a very has a complex medical history, and I'm kind of her advocate in all of the things. And so it starts by understanding what's available to you and, what your rights are and advocating for that. And then using your lessons learned as a platform for additional conversation of what needs to change. I think elevating your own voice, but then voice of others in your community around their experiences is really important. I think we often talk nationally, the big picture, the large health outcomes. At the end of the day, it's a person that's being impacted. It's my mom, it's you, it's your daughter. We need to use our voices with our names to talk about the experiences we're having and advocate in different ways, including to your provider of what you want to see differently for you, understanding that your provider is often your partner, like approach it as they're your partner, not your enemy in it. But then use your voice to advocate broadly too, if you have a position where you can do that. And, I personally feel blessed that I have a position where I can share my story and the impacts that Medicaid has had on my life and has on my mom's life, the good, the bad, and the other way. And that I personally am able to experience it as a caregiver and then use that as ideas and impetus to continue to spur change.
I think, my 92-year-old now aunt is a dual eligible Medicare Medicaid patient in Chicago. And I think it's a very unique experience, not that unique, of people who are CEOs in healthcare who have decades of experience in this, still really struggling how to navigate that program for somebody, right? And how do you get somebody enrolled? How do you get them the services that they qualify for? I know it's just fascinating being on the inside of it and trying to help my aunt. In some ways, it's incredible. Shout out to Chicago's incredible assisted living waiver program that puts her in a beautiful assisted living facility with PT on staff and primary care on staff and nursing on staff, and just an incredible program. And then also, why are some other things just so hard? Right. And why is it so hard to even recognize that role of a caregiver for somebody on Medicaid? Right. It's this dual-edged sword, I think I experience, and I'm curious if it resonates with you, of, the systems are set up that you need to be like an individual. It's not a family program taking somebody into that program. But then at the same time, it is impossible as a medically vulnerable person to navigate that system on your own, right? And so how do we remedy something like that, right? Like, what is it that the system is actually asking us to do here?
Yeah, well, it definitely resonates with me. I do find it fascinating where if I'm struggling to understand, as you mentioned, how are others, going to understand? And I've spent my career in this.
Mm-hmm.
I am doing this because I have seen firsthand the impacts of this, and it's my desire to really kind of leave the health system better than when I entered it. If I still struggle, then, what does that mean? And I think that that's where I get, like, my hope there is some of the shifts that we are seeing. For instance, I mentioned with community health workers, I
Mm-hmm.
think understanding that the cracks and the fragments in the system are leaving people, in the dust, and they're not able to really engage in healthcare in the way that they need to. So if they don't have the opportunity to have a caregiver by their side that's a family member, bringing people to their side who are community health workers or promotoras, or people who understand the community but also understand how to navigate some of those gaps in the systems, or those best practices of this is who you call to talk to the person who's actually going to give you an answer here, is really important. So I see hope in that. I see that there's starting to be a recollection that there is fragmentation and people are falling through the gaps. So we need to support people in that. Hopefully, as we continue on through the decades, that'll only become like the core standard of care and not on the fringes of waivers or Medicaid delivery.
And truly a bipartisan issue, right? I mean, I think so much of the progress and the direction that we're seeing in things like the Medicaid transformation programs is about, each talking point is like, you could ping pong it back and forth between a Democrat and a Republican talking point. It's about, empowering community leaders who are established, who already know how to do things the right way. But it's also about social services. And it's also about, just this lived experience that we all have in healthcare that really is so far outside of a political talking point right now, of just how we all know it's not working in the way that it's supposed to be working, right? And how can we try to change it? We have another comment from Andrew saying, tech is so hard to localize. So much of the tech infrastructure is not built on that layer. Take a closed loop referral platform, for example. So much of it is, does our FQHC and our local CBO use the same platform? Likely not. It's hard to get people on the same social media platform, let alone the same referral workflow platform that connects things like health records. So yeah, what do you think about that?
I think Andrew is 100% right. That's part of, what we're seeing right now, and part of the, for no better term, like the waste and the redundancy that we're seeing. My personal opinion, not the opinion of Intrepid or others, but what we're seeing right now, for instance, closed loop referral platforms, because it was raised, is that more and more organizations are starting to build closed loop referral platforms. And I feel like we have so many, we don't need another one. I think what we do need is a core set of, standards. Either, I'm not going to go as far as say one platform, but a core set of standards across platforms that can then exchange with one another. With the ability to figure out what those local use cases are and design around them. Some of the work that we've done over the last couple of years related to the data exchange framework is bringing communities together to figure out what are those localized use cases, because there are, shared platforms that organizations can connect to, but they should be thinking about collectively what their needs are and how to kind of modify or request modifications of some of those platforms, additional features, et cetera. So, I mean, to Andrew's comment, I think that that's where we're at right now. That's kind of the stickiness and the chaos, so to speak. I do think that we need to start moving in a direction where there's some standardization. I also think that we need to move in a direction where there's standardization in the data elements so they can be exchanged, and that platforms do exchange across. So, there are going to be different, again, closed loop referral platforms because of what it was raised. There are going to be different platforms that are implemented in different, localities, but they should be able to talk to each other in different ways and still coordinate that care for that one individual.
And that's a great place for a national set of standards to be created. So that then individually, if, Ukiah wants to build their own closed loop referral system, they have to still be on that same standard, right? Is maybe one way to approach it. All right. Well, we are almost at time. So I want to make sure we have time to just make sure, is there anything else that I should have asked that was, really on top of your mind as we got to connect today? And then we'll talk a little bit just about what you're reading and listening to and what's inspiring you.
Yeah. I think, not that you didn't ask, but one final thing I'll offer is how important measurement is. I mentioned it a little bit, but I definitely think one of the values of local implementation is that you can measure locally. And I mentioned, like, healthcare is me, healthcare is my boys, healthcare is you and your daughter. So we need the individual stories. We need to understand at the individual level, what's the impact? How is this changing lives? But then we also need to understand at an aggregate level, are we driving towards improvement and where we want to be going? And I think that that's often missed. And I would say, in thinking about like local advocacy and thinking about what does it mean to have healthcare be local and advocate for local design, it's going to be a lot easier to do that if there's data that you're bringing with it. So as you're thinking about platforms that you want to be implementing, as you're thinking about new programs, as there's this design locally, really thinking about what's the data that you're going to be measuring and looking at to see working. And then use that as a platform to be able to have conversations of the value of local implementation, I think is really important.
I was reading a very interesting book. I'll put the link in the comments, but really talking about just starting to play with the idea of, does the measurement need to be tied to the reimbursement in the way that we're doing it right now, right? And is it possible to measure things without applying that incentive on it that then starts to corrupt that measurement and starts to make that like something that's, the cheese in the maze for people? Is that something you've been thinking about too?
Yeah, I mean, I think the way I've been thinking about it is, what's the definition of ROI, right? Like within healthcare, we go very quickly to financial ROI. I personally think that we need to think broader. It's not just about the finances. As a CEO, I totally understand the finances matter. But the point is not let me reframe that. The point should not be solely to reduce cost. The point is the impact that this has on individual lives. And so I think we need to think more broadly about the impact and the why of why we're doing any of this. I mean, it should not be just about cost reduction. Is our healthcare system costing us way more than it should be for the outcomes that we are getting? 1000%. But that's not the only point of our healthcare system. Around what that measurement looks like and what ROI is in particular.
I'm writing a book about money in medicine right now. And where I'm kind of landing, at least in this middle point of it, is, yes, like our healthcare cost is a huge problem, right? And there's like many, many facets to that. But also I would gladly trade keeping the amount that we spend, but having incredible outcomes and having really super happy, healthy lives. Like I pay $2,100 a month for my health insurance. Like, sure. Yeah. Okay. Like I could keep doing that if it, and it actually is like paying off and like people are actually really thriving. I think that is a different way to think of it, sort of, instead of like the austerity approach of like, well, let's just spend less, but also just continue to have terrible outcomes.
Really be like the system needs to be working for the people that it's serving, and it's not right now. And I would say, a theme that would be interesting for you to explore if you're not, is the difference in equity across that. And some individuals very much could, and I would advocate should pay more, whereas others, the impact of that on others is much greater. And so how does that play into thinking about, health ROI and kind of the impact on health outcomes overall, and financing within healthcare and what should be there?
Oh, I love it. Well, I'm so excited to see all these things come into fruition, for people to be paid to participate in conversations about emerging out of the ashes of our current healthcare system into a beautiful phoenix, and to hear those stories locally and regionally all across the US of like how people are really doing that work. With the last minute that we have, tell us some of the things that you might be reading or watching or listening to that are helping to shape how you think about all of this.
Yeah, right now I'm listening to a lot of health policy podcasts. It's like my go-to running listening is things like the Health Tech Talk Show is one that I've really been enjoying, or the Policy Stack podcast, or What the Health even. And reading right now, I'm reading The Empire of Pain. I don't know if you've read that one. It's looking at the Sackler family and kind of the development and the work of the Sackler family, and then the impact that that's had on the epidemic. I've personally been touched by the opioid epidemic, and I've professionally worked to reduce misuse and abuse of opioids. And so really kind of thinking about and looking at the family history of what really created that has been really interesting for me.
I'm adding it to my reading list. Well, thank you so much, Dani. Thank you for being here. Anybody who's interested in learning more about the work that you're doing can go to Intrepid Ascent's beautiful website that we helped to create for you guys many years ago. There's the URL there. Beautiful. But yes, I think what a great day and moment to take our time out and think about all these moments of optimism and progress that are happening in regions and cities and towns and counties all across the US who are starting to hopefully tip that scale back towards taking things into our own hands and building the systems that we want for our own neighbors and our own regions. So thank you so much for being here today.
Yeah, thanks for having me.